So let's get started with today's clinical topic. And our returning champion is Kathy Bassett. She's formerly professor of dental hygiene at Pierce College and an affiliate professor at the University of Washington School of Dentistry. She was here last month talking about anesthesia in the mandible, and it was a great lecture filled with really, really practical advice. So we brought her back to talk about the maxilla, and I'm excited to turn this over to you. Kathy, welcome back.
Good morning. I don't know where everybody is, but for me, it's good morning. And thank you for having me back. So moving right along, if you were here with us last month, yes, I do speak quickly, but I have a lot of things I just kind of like to plant some seeds. And so if you just really kind of look at that as really tips, and if you want to take deeper dives into more instruction, I have suggestions for that along the way. So kind of first order of business in most cases is just my disclaimer that I do not have any financial interests to disclose that would impact my presentation today. So if everybody would just, get your phone ready or get your screenshots, the next 6 frames are going to be my top resources for today that I think are relevant to this content. And I really encourage you to go dive into a bit yourself. So on the first frame, and I'll stay about 5 seconds for you to grab it. On this one in particular, item number 3 provides in-depth injection instructions and also includes techniques that I talked about last month. So if you're looking for something to give you a little bit more of that bullet point approach, that item number 3 will really help get you there. On the next group, on this one, item number 6, also we go through, this is actually a textbook that I'm part of. And again, we have, very specific step by step. So those are good places to go for more in depth. And then the next one is actually, housed in Glidewell's library. So on YouTube, Chairside Live, episode 81 is we do a complete AMSA injection, start to finish, and a really good discussion at the end. So that's really a good place to go to work out the mechanics of that AMSA injection. And in that one in particular, we did it with a C-clad device. So you'll hear a little bit of the nuances. And if you're curious about that technology, put that in your technology basket. You'll get a little bit of that information as well. The next frame is just, if you don't already have this chart at quick reference in your office, here's just a quick grab and go list of the FDA local anesthetic MRD guidelines. And this would be for healthy patients. And then the next frame is the American Academy of Pediatric Dentists guidelines. And these were new as of August 2023. And so if this is not a document you're not familiar with, would be a valuable one to have in the office. Coming up is the QR code. So I'll let you grab that, and then you can just download that whole guideline. And also you're going to be right at that library, and there's really great information. And in this one in particular, it's not just the numbers, it's also the philosophy behind. And in that category of managing pediatric patients, there's a lot of information, and it's not just about dosing. And it would also talk about if you're dealing with essentially minor pediatric patients that may also be pregnant patients. And there's a lot of good discussion in there. So I highly recommend you add that to your library of resources. So my goals today actually go beyond this list of objectives, and that I hope to leave you with some new perspectives that you might consider in the way you approach maxillary anesthesia. And ending with the last few things is I'll go a little bit deeper into that update, particularly around the pediatric dosing and other FDA information. So step 1 is looking at the anatomical considerations. And for today, my focus really is on the maxilla in relationship to the maxillary nerve and the nature of the bone. So in the orange circle, keep in mind, this is where the short exposed segment of the maxillary nerve is. as it exits foramen rotundum off the trigeminal ganglia. And then before entering into the infraorbital canal, where then it becomes protected by the bone within the maxillary dental plexus. And then in the orange square, note the porosity of the bone of the maxilla and the palate. And then look at right there between the green and the beige there, that junction where we have that palatine bone segment of the hard palate. And that's going to become relevant when I talk about greater palatine nerve blocks and true maxillary nerve blocks a little bit later. And here again, you can see that junction from another view. And just really quickly, you'll kind of see that orange dot. That's where most people will give a greater palatine injection. But I want you to just, hold that image as I get to that later as to where we tend to go versus where anatomically that opening actually is. So keeping your eye on the orange circles, note this is the only area where we can deposit anesthetic in close proximity to the maxillary nerve before it enters into bone. And this is actually similar to when we're giving an inferior alveolar nerve block right before it enters the mandibular foramen. So finding that location where we can get adequate anesthesia close to that nerve then impacts, the greater field of anesthesia. And in most cases for the maxilla, our target nerves are protected by bone. And the only real exceptions to that are, where the free nerve endings are exposed there at the infraorbital foramen, at the nasopalatine nerve endings as they exit the incisive foramen, and then the pathway, the greater palatine nerves. And then keeping in mind that only impacts soft tissues. So visualizing aspects of the pterygomandibular space. So we talked about the pterygomandibular triangle, the pterygomandibular space last month in relationship to the inferior alveolar injections. And now we're just moving up more superior in that same space. And depth and angle decisions really do matter. I've had a lot of people over the years kind of say, it doesn't really matter if I just kind of get in this region. And I'm kind of wanting to punctuate here that there are some features that make a difference. And if we get enough anesthesia there, we're going to have better outcomes. And at the same time, keeping in mind that the higher we move up in that pterygomandibular space, the higher the risk for potential hematoma can be. And then that's when we need to make some decisions about when and where we might use alternative injections to accomplish those goals. So on this one, to take a minute to orient yourself, the blue brackets are the location where the zygomatic arch has been cut away. And particularly in this upper right on the lower edge, I'll always refer to that eminence of bone as the zygomatic strut. So if you hear me say that. In the areas of the orange circles, again, that is superior, deep aspect of that pterygopalatine fossa. And this is the first point of access to the maxillary nerve as it enters into soft tissue space. At the left and lower right, notice that the PSA nerves branch off and are generally bound in the fascia. So here in the lower right, here in the circle, here's where the root of our maxillary nerve is coming out. And then we have all of these branches that are literally tethered with fascia. So if we're too far away from that, those nerves are going to also have some protection from the fascia itself. So we're going to have distance and we're going to have density that we have to move through to really achieve profound anesthesia back in those areas. In the upper right, if you look right in the orange circle, you'll see that shadow. There's the opening where that nerve's going to come down. And that's the location where we have opportunity to, again, access that segment of nerve before it's protected in the bone again. And that's right in that little crevice between the lateral pterygoid plate, the maxillary bone, therefore our pterygopalatine fissure. So looking more closely, pulling this all in, again, start the orange circle in the pterygopalatine fossa. And we're looking here, again, right at the root of that nerve because it comes across right here And then we see our other little branches. And then number 3 is the artery. And number 4 is the maxillary artery. We have the branch coming off. And then here again, you can see all of that tethered onto the back side of the maxilla, and again, protected by fascia, and then, pretty quickly then protected by the bone. In the gray, those are the nerves we talked about last month. So just kind of for perspective. And I like this picture because I'm one of those people where it doesn't matter if you give me a PSA or you give me an IA, I'm going to get some anesthesia of both because my anatomical proximity is really close. So it's just a good, good opportunity to just remember that when you have patients, telling you that for many, those things are very close and you are going to have enough anesthetic in that area to impact adjacent nerves. Okay, now I'm going to pull in even closer just here. So in zooming that up, again, to reorient, that blue flag, that's again where the nerve is going to come through. And here is where we're going to be able to access it. So if I can get drug to this space from a lateral or a medial perspective, then I'm able to put anesthetic in this region before it enters into the bone. And again, has, more protection from both bone and fascia. And so, if you see it coming, we're kind of setting up for a discussion about actually a true maxillary V2 nerve block. And many people will just say, I gave a maxillary block. Well, if your intention was in that region for posterior superior alveolar nerves, it's really more of a smaller field block. And if we don't have that closer proximity actually to that exposed segment, that actually is not a true V2 nerve block. And there's likely going to be other branches that you're not going to be able to access. And then additionally, as the nerves move down through this space, there also are the branches that will then go on to the nasopalatine and greater palatine. So we need to isolate in the same way. If I was giving an IA, I'd be above the foramen. And here I want to be adjacent to that fissure to maximize the impact of the drug distributed there. And on the bony specimen, again, here's the space right up in there. And notice how high it is. It really is up at the level and behind the zygomatic arch. So when most of us are giving anesthesia for those molars, we'll be addressing potential infiltrations along that group of teeth. If you approach it as a true PSA nerve block, then your target is generally, at least above the maxillary tuberosity. But most of the time, it doesn't really go, much further up behind. So just the same conversation is with the IA, we need to go higher. In this case, if we want to have a broader field, then we do need to go higher and really separating that from the implications of simply infiltration. And I'll talk about that again in a little bit. So kind of summing up those anatomy tips, keep in mind that if you're giving a PSA injection and your intention is those maxillary molars, that in a large percentage of the population, those teeth are also innervated by the greater palatine nerve. So avoiding a greater palatine injection actually could be setting you up for incomplete anesthesia. And a lot of people have hesitation to do palatal injections. And my encouragement is when done thoughtfully, they can be very comfortable. And also then we're going to get that collateral innervation that could be what's undermining your success. For the middle superior alveolar, most of us learned in school that a lot of people don't even have that branch at all. So we go in and we give that injection in the region of the bicuspids. Our intention is to capture those premolars. But if that nerve isn't there, then it's kind of like, well, how are we really getting, those teeth? So then it becomes more of, infiltration anesthesia. But keep in mind that predominantly they found that when in the absence of MSA branches, that there tends to be an extension of the PSA branches. So again, getting profound anesthesia from the PSA also can be the answer to having more profound anesthesia for bicuspids. Moving on to looking at the palate, the key features here are in the palate is in the area where the terminal branches of the nasopalatine and greater palatine are generally accessed outside the bone. So anything that we do, wherever we put that injection, then that anesthesia is going to run you anterior to that on the GP, posterior to that on the NP. But if we aren't back far enough for the GP, we could end up missing a significant palatal lingual aspect, again, for molars. So if that's the area that the patient's having discomfort and they have that supplemental innervation of greater palatine nerve into palatal roots, then we may not, be able to establish profound anesthesia, particularly on second and third molars. So my encouragement is when you're doing significant treatment on the molars is just make it your workflow, if you will, to do that greater palatine in addition for molar anesthesia when you've given a PSA or infiltrations on first through third molars. Looking at this more closely, and I'm going to propose that most of us learned to give our greater palatine near the distal of the second molar, when in fact that greater palatine foramen is just a very short distance from the posterior border, and it's really not near the first molars. It is actually, well distal to the third molars. Then if you add into that missing teeth, bicuspid extraction, missing third molars, then that location can now be artificially even more anterior to where those nerves are actually coming into the bony structure. A feature to appreciate on the palate is how porous the bone is. And together with the inflexibility of palatal tissues, drug can quite efficiently be moved into that dental plexus through the palatal aspect. And this enhanced diffusion of anesthetics through palatal bone is the basis of the AMSA injection, which we'll look at. And it really allows you to leverage what we know in pathology is pathway of least resistance. So if we combine this compressive feature of attached gingiva to a porosity underneath it, then in fact that drug can be easily motivated to move through that palatal tissue. Tips to keep in mind for palatal anatomy variations is that fibers from the anterior superior alveolar nerve frequently travel right along with the nasopalatine. So for many people, when you give a nasopalatine, you will also get some anesthesia of the incisors. And with some technique variation, you can actually capture both of those simultaneously for some profound anesthesia to incisors from a palatal approach. And again, my perspective is when done with thoughtful steps, you can accomplish those palatal insertions pretty comfortably. And a lot of the discomfort's really on us. And if we shift up our game, then we can actually leverage those palatal insertions to our benefit and the patient's benefit and do it in a really comfortable way. The other one, and I mentioned that one, is that just keep in mind that foramen is more distal than we think or more distal than we recall as we start choosing our targets based on teeth. And one thing that I kind of say, and particularly when I'm working with my students, is with the exception of single infiltrations, you can take all the teeth out and do each of the techniques in anesthesia to perfection, because there's a lot of skeletal references that are more valuable than individual tooth references. And when you look for those, then that gets you more to the trunks of those roots and before they innervate greater extent of surfaces. So in summary, here's a few additional things to think about. So this is no mystery to any of you, but sometimes it feels like luck is the key principle for successful anesthesia. So you walk into the operatory and grab your lucky ducky and say, okay, we're going to make this work. And that's probably what we feel like a lot of times, particularly with that patient, that every time this is just a challenge. But just take a pause, consider those anatomical features that are relatively consistent for all of us, and just moving your positions a little bit, changing your angles to consolidate drug closest to those root trunks may be the difference between well-planned injections and just plain luck. So on the on comparing infiltration versus block techniques, and here's just a few bullet points on that. Again, this is just consider for a moment and just ask yourself the questions: what do I need to have known? What drugs am I using? And what's the difference in these injections? And we're discovering that with the use of articaine, we can be more efficient with infiltration anesthesia because of that diffusion, and the lipophilic properties of articaine allow us to, be more in these discrete areas and really get profound anesthesia. And that's sort of changing the way that we look at a lot of our anesthesia treatment plans. So our checklist of injections tends to look like this. Am I going to do an infiltration? Am I going to target for ASA or MSA nerves, or the infraorbital for the anterior segments? The PSA nerve block, am I going to do that shallow or a little bit deeper, or am I just going to infiltrate molars? The nasopalatine, and also the palatal ASA injection, if you haven't seen that one before, and then the greater palatine and the AMSA. These are all ways to approach your anesthesia from the palate that actually give you profound anesthesia, and you don't need to additionally do anesthesia from the buccal. And then there's the true Division II maxillary block if you just have someone that there's just lots of things in the way. So example, I live near a military base, and so I will see people who have significantly altered anesthesia from trauma injuries, and the nerves aren't where I expect them to be. So I need to think very differently and get to root areas because their anatomy has changed and their nerves are not where I'm going to expect them to be. And then last month, we did touch on intraosseous and PDLs, and the same theories apply here, that those can be rescue injections and administered in the same way that we would for any mandibular situation. So my comments here will be: retraction of the lip really can make a difference. And if you lift the lip upward and then kind of outward, like you're creating a backsplash, it literally lifts the tissue up and it opens up that pathway. And so on that insertion, you're less likely to bump against periosteum. And then really looking at that person's maxillary slope and getting parallel to that bone avoids contact with the bone, because we don't have any intention to make contact with bone. It's not necessary for these injections. We're estimating the height of the apice, and we just need to get that drug adjacent to it. So if you regularly make contact, I encourage you to just shift that angle a little bit and work to not making contact. And I think you're going to see a lot of change in the behavior of the patient in response to that. Additionally, we can see that same nature of, opening that area up, gently lifting tissue lateral. And this is opposed to folding it back, pulling it upward, and literally compressing all the tissues against the maxilla. And then again, that makes it harder to move through that space without making contact with the bony contours within that space. And then on the MSA, rule of thumb is actually go more over the second bicuspid. Statistically, the MSA nerve enters into the second bicuspid more frequently than the first bicuspid. For an infraorbital, if you use this injection, and if you've kind of been taught to be nervous about it, I'd encourage you to kind of rethink it. And in this case, again, that retraction is important. Lift the tissue lateral versus folding it up so you clear that pathway. It's going to be just under the rim of the bone. And you hear people say, I don't want to go, into the eye. In adults, patients, this is, very dense bone, and just keep in mind that the body protects high value assets. There's really dense bone protecting the high value assets of the eyeball. So if we're depositing our solution here underneath the foramen, near the foramen, and again, we aren't, challenging that bone, the eye is protected. We're not going to enter into that and actually come in the bottom of the orbit. It just doesn't work that way. And then here on the right, you can actually see in a dissection. So here's the eye, here's the edge of the tissue that would be right over the orbit. And then you can see this fan shape right here. Well, there's where the nerve comes out, the foramen. And then here's the area where all of this area here, soft tissue, is innervated by that infraorbital nerve. And for the 20% of the population that don't have that MSA, these nerve branches and those branching off within the bone are likely to be what's bringing sensation to particularly the first premolar. Quick reference point on this is when you are looking at this one, is here is the height for an adult. And on the blue, if you looked at a child's rim is only approximately this tall. In an adult, that's about 8 to 10 millimeters. In a child, it's about half that much, and it is much thinner bone. And so the likelihood of piercing through that is possible. And so this injection would be contraindicated for children. On the PSA, angles count. So on this one, we learned, initially that I use language different than what you were taught. So you may hear that they would say you need to go upward and inward. And people would go, I have no idea what that means. So just keep in mind basic thoughts. Number one, I want to bring my hand downward so the needle will go upward. I want to bring my hand outward so the needle will go inward. And the biggest mistake a lot of us make is we'll retract that lip up. When we do that, we pull the lower lip right into our pathway, and this injection tends to be flatter, and we don't reach that higher level that we're trying to achieve to get that drug near where the PSA nerves are tethered onto the posterior surface of the maxilla. So that 45 degrees outward and downward are important. And if you look at that in a bony situation, here's where my fingers retracted, and you'll see that I retract downward so that I intentionally hold the lower lip out of the way. And then as I enter in, as this image on the right, that allows me to go up around and get that drug up behind those teeth, again, where the nerves are going to be tethered onto the backside of the maxilla. Looking at it here, the PSA versus the maxillary V2 block, and I kind of set up that conversation in the beginning, is here's where our insertion levels are traditionally for what is a common posterior superior alveolar nerve block. With a short needle, I'm going to insert in till the front of that wide hub is just about lateral to the CEJ, and that puts my needle tip right about here. But from that earlier discussion, here's how high up that fissure is. Here's where the maxillary nerve is coming down and through. So I need to increase my depth up to here. This is about 16 millimeters of insertion. And in order to get my drug up there closer to the maxillary nerve, then I would need to increase my insertion to about 30 millimeters. The deeper I go, however, now we need to really consider that increase in the possibility of hematoma because we're so close to that maxillary artery, which is why they started reteaching us PSAs shallower. But if your intent is, I'm not having success with that, I want that broader field, you may find achieving that deeper insertion can be beneficial to achieving a true V2 nerve block. A couple of tips on just nasopalatines is what I notice a lot of people do is they'll actually enter right into the soft tissue of that incisive papilla And then you'll get a real like egg white blanching of just the papilla. Just keep in mind that that's then holding it in the fascia. It increases the possibilities of necrosis of those tissues, and it's not getting the drug underneath that kappa tissue. So making that 45 degrees, we want to literally make contact with the bone down in here underneath that kappa tissue. So, look and see where you are. And I encourage you to really be at a 45 degrees to go under that rather than very flat, which puts you right into the papilla. And then on the right, here again is where most of us were taught to do a greater palatine nerve block, and this will not capture anything posterior to it. So if you need that anesthesia for the lingual of second molars or more posterior, this is too anterior, and it is in fact approximately 3 teeth anterior to where that canal actually is. So if I'm looking at a standard NP, and I made comment of a technique called the PASA, and this was actually crafted for administration with a computer-controlled anesthesia device. And all they do is they change the direction just a little bit. And so rather than entering from the side, 45 degrees, make contact with the bone, we insert more anteriorly, and we intentionally travel into that frame a little bit further. And they have documented that administering here allows you to actually capture that whole anterior segment. So you can end up getting pulpal, lingual, and facial gingiva anesthetized with this injection, and it will not impact the labial tissues. Anytime we're giving any palatal injections, and I just can't say this enough, and the number of times I've really watched the opposite happen, just please slow down. One of the things when you're using pressure before, it takes the body 50 seconds to realize that that it has another signal coming. So gate control response doesn't kick in for about 50 seconds. So you need to use a full minute and then go slow, because the injection hydraulics in this area, the pressure coming to that needle, can really cause trauma to those tissues. And that's what the patients are responding to. So if we hold the pressure to a full minute, slow that down to about 3 minutes for palatal tissues for a whole cartridge, then we're going to have better pain management for those patients. And for me, that's a whole lot better than saying, oh, by the way, this is going to hurt a little bit, just hang on. For your box, what I'm going to encourage you to do just, at chairside is just have sterilized cotton swabs available, because in this way you can apply the pressure, make contact with that needle, and not worry about contaminating the needle. So when I give a palatal, you'll see that I just hold the cotton swab right there at my point of insertion. It literally helps stabilize the needle a little bit on that insertion, but any drops I immediately pick up. I just don't even, risk the patient tasting them, because we all know that that bitter taste can be more annoying than actually the discomfort of the injection itself. And I see that we are at 10 minutes to go here, and I obviously overplanned for today. And so I'm actually going to pause here and just check in with the moderator and see, do we want to continue for 5 more minutes, or if you want to jump to questions?
I'm okay with you continuing.
You're great? Okay.
Yes.
So the next segment here, I want to look at an AMSA injection and a maxillary V2. And the main thing here is these slides are for introduction purposes, and please don't consider them to be complete instruction, but I will refer you to resources that can walk you through these step by step if they're ones that you'd like to explore and consider adding to your approach. So the first thing I just kind of throws a little bit of trivia is, do any of you know how the AMSA injection was discovered or crafted? And I love this because Dr. Mark Hockman, who is the patent holder on the wand, and the group of people that initially started that group of C-Clad technology, they actually worked this injection I'm going to show you out on themselves. And this is one of two friends of mine that actually will go and they do their own injections for their own dentistry. And I assure you that is not me. So to do this AMSA, what we're going to do is we're just going to, leverage the nature of the tissue. Again, that porosity, think back to those pictures I showed you in the anatomy, is if I put the drug in the right place, the pressure of the attached tissue is just going to keep it moving through the tissue. And so the AMSA was crafted for aesthetic treatment. And when the goal is you really want to be able to map out that patient's zenith line, this will provide pulpal anesthesia while not creating labial anesthesia that gives you that droopy look. And so the first part is you just palpate for where the thickest tissue is between the bicuspids. And you're going to go to the height of the alveolar process, where it is the junction of the horizontal part of the palate. And you're going to then palpate for the squishiest little pad to help accommodate the tissue. And then your insertion's right there. And the way to think about this is to aim the bevel towards the palate. And just imagine then you're going to park that diagonal of the bevel against the bone. And that will help you figure out your vertical angulation. So I just kind of think of it like on Star Trek and the ship's coming in and docking itself. As I dock the needle facing the bone, and then I just hold that position. And here's where that 3 minutes becomes important. Then I'm going to maintain a flow, which seed-clad devices do for me. And I'm going to administer approximately 1/2 to 1 cartridge, depending on how much that tissue can accommodate. And what we see when we're having success with that is this blanching pattern that it extends from the incisors to the first molar or more distal, and then right to that median raphe. And you'll just see that whole hemisection of the maxilla of the palate there all blanched. The interesting thing about that as well is not only does the drug distribute itself anterior posteriorly, but it literally has the ability to diffuse through the bone. So in this first image on the left, this is what it looks like right after we give the injection. In the middle, we're looking straight up, and you can see that blanching passing through. And then here's on the buccal, approximately by the time I gave 2/3, 3/4 of a cartridge, and then I lifted up the lip in that approximately 2 to 3 minutes, you can see the diffusion clear through to the buccal. Now I have pulpal, buccal gingiva, and palatal soft tissues all anesthetized, but I don't have any interference in the facial tissues above that. And for this one, you can go to that Glidewell episode 81 on YouTube, and you will see this start to finish that will walk through that entire injection with all of the detail. This is highlighting now on the maxillary V2 block, and there are 2 ways to approach this. And we either approach it from the buccal insertion, or we're going to approach it from the palatal through the greater palatine foramen. So back to our orientation, orange circles, where the nerve is first coming off the trigeminal ganglia. Our first aspect to get drug to that nerve. Here's the maxillary artery. Again, that's going to increase possibility of hematoma in that area. And in this one, when you start, everything looks just like a traditional PSA, except here I'm back to using a long needle. And I'm going to make that insertion approximately 30 millimeters to get me up to this height. The needle on the image is at 16, my target for a PSA. With a long needle, I can extend that distance to put me into that orange circle. Now, when I look from the palatal approach, I'm going to actually navigate through the greater palatine foramen. So on this particular model, please see that they have both their bicuspids present, they have the third molar present, and there's the greater palatine foramen. It's clear back near that junction of the horizontal process of the palatine bone and the palatine process of the maxilla. It's in that most posterior segment. So in order to navigate this injection, you're going to locate that greater palatine foramen. And then we're going to anesthetize here to allow us to probe the area a little bit until we actually engage the foramen. Then we're going to travel through that foramen so that the needle tip actually exits out in the pterygopalatine fissure. And to do that, we're using a long needle, same as we did from the buccal. In this case, we've bent it a little bit, a few millimeters from the needle hub to allow it to have a straight angle upward into that fissure. And then we're going to insert to a depth of 30 millimeters. And when it comes out, what it looks like within the tissue is it's coming out right here. So by entering through the greater palatine foramen, we travel a relatively short distance and the needle tip will emerge in the fissure. And when we make our deposition there, again, we get it before all the other nerve branches have come off that main trunk. In this one, it is important to be careful. A lot of people aren't comfortable navigating that canal. If you have any resistance, the instruction is to pause. And then the biggest piece on that would be, they also find that if you just even partially engage and go ahead and give it, many times you can successfully capture that, even if the needle hasn't navigated that full 30 millimeters up into that space. So here's just my last few things, and let me check in. Would you like me to keep going?
Yeah, if you have a few minutes, that's
Okay,
fine.
yep. We have just the last little segment here, and then we'll marry it all together. So just a few highlights from pharmacology that fit with what I've been talking about today. So we go back to the fact that successful anesthesia, we need to respect basic neuroanatomy and pharmacology. And this is that principle that nerve membranes are made of protein and lipid. When we enhance the protein affinity and lipid solubility, we enhance diffusibility, onset, and duration. Those that were here last month, we looked at this slide and just reminding you that we all understand that bupivacaine is a long-acting drug, and that's due to its rigorous protein binding capacity. But it's also important to note that articaine has nearly equal affinity in those sodium channels. And in the maxilla, this is evident in how easy it is to achieve anesthesia of those nerves that are housed in the maxillary dental plexus. Because think about, pretty much everything we do in the maxilla, that drug has to move through bone. And articaine does that very well, and then additionally anchors into those sodium channels. The reason from a pharmacological standpoint is it has a different structure on the lipophilic portion of the molecule. And when they add that thiophene ring, then it has the ability to diffuse more rigorously through those tissues. And here's a really interesting article. So pause for a minute, and these two pictures are in fact the ones I showed you before. When we give an AMSA, we see that that blanching pattern moves through the entire alveolar process, and we see that blanching on the buccal. And this is an article that looked at another aspect of this. And in this article, they did the initial injections on the buccal, and then they checked for the concentration of the drugs on the palatal side. And one of the most interesting parts about this is that they found that both lidocaine and articaine, when administered on the buccal, will move through the tissues. But they found a significantly higher concentration of articaine. So articaine more rigorously diffused through and also impacted some anesthesia on palatal tissues. Now, as a hygienist, that's really valuable to me, because then I can see that for a lot of hygiene cases, just even doing infiltration, if that's what I'm comfortable, or combination of a PSA and other injections, anterior injections, I can get lingual comfort as well. And then also I have the option of using like an AMSA. And either way, I can approach my anesthesia plan from just the buccal or just the lingual and actually, feel pretty confident that I'm going to get the anesthesia I need when I'm using appropriate volumes. And I have just two more things I'd like to point out here. Just reinforcing, please, if you don't already have them, hop online, use that QR code and grab this table for pediatric drug doses. The other thing I just want to put in the update your information category is, if you don't know this, that in 2015, the FDA repealed all of the ABCDX drug classification categories. They are no longer put on any medications. Nothing new in the system will have that classification system. And so in dentistry, I think we became a little complacent in saying, oh, if I'm asked that question, I have a concern in pregnancy, then I'm going to go and use that B or C drug. What I encourage you to do is pull out one of the directions for use out of your local anesthetic drug boxes and read them. And what you're going to see is these classifications don't exist in those handouts anymore. And this is no longer the way we are instructed to make those drug choices. The shift now puts on drug packaging a narrative, and it will have a summary of the risks, clinical considerations, where the supporting data is, and then there's a subsection of that on lactation and, well, with breastfeeding. But the clinical interpretation is up to us, is up to you. And then we need to work with those individuals and their healthcare provider to decide how to approach this. The thing that becomes interesting with the dental drugs we use is we're not going to get those categories, because all the drugs that we use were on the market prior to June of 2001. So they are required to pull out the ABCDX information, but they weren't required to then put in those narrative categories. So again, that's going to move us to having, higher level conversations with primary healthcare providers and pregnancy healthcare providers than maybe we did in the past. But just, understand that we cannot any longer communicate on that ABCDX, because that's not, in fact, a viable system in the United States. And one more comment on that will wind me up here is I was gifted the privilege of attending the Global Pain Management Summit in Paris, France in September 2022. And this is actually something I have in my handwritten notes. And it was a lecture being given by Dr. Greg Mahoney from Australia and Dr. Micah Sobatsky from Poland. But these are really important when we're looking at those drug tables. So reduced dosages in pediatric patients because they have underdeveloped organs. And we need to be prepared to reduce dosages in geriatric patients because they have reduced function of those same organs. And a lot of times, I think we just look at the chart, people think everybody can go to that max, but we need to be making those dose adjustments for the population that we're actually seeing. So thank you for that time to get to the end. And if anybody has any questions, we can do that.
Absolutely. Thank you so much, Kathy. This has been so great to see you on these series, and it's just been so much wonderful information that we can take back, today. So on regarding the new school criteria and pregnancy, benzocaine topical anesthesia, do you have any thoughts on pros and cons for pregnancy?
The thing with benzocaine is it has an increased risk for methemoglobinemia, and that's actually because it's an ester drug and not an amide. And there are, many years ago, there were published precautions for use of benzocaines with pediatric patients because of that higher risk. So what it's going to be is about the higher incidence of methemoglobinemia. And also you will see in the pregnancy guidelines, prilocaine is no longer on their table. And that's another thing with prilocaine is it seems to, among the amide drugs, also have that higher incidence of methemoglobinemia. So I'm a little more conservative, but also if you control the volume, if we don't go in like with what it looks like we got the cotton candy, at the fair, get the teeny tiny bit, control your doses, we're probably okay. But if you have hesitation, it's not misplaced, and it will be because of methemoglobinemia.
Great. Thank you so much. And then there's a little bit of an experience that somebody's asking you about. So it's the first time they've been practicing for over 40 years. They infiltrated with a 2% 1 to 100,000 epi on 8 and 9. The patient ended up with a minor nose bleeding shortly after the injection. Do you have any opinion as what could cause
I have a theory,
Yeah.
I could, it's like when you ask that, and if you were at the dinner table with my dad, who was a dentist, we'd be saying, well, this is interesting. Here's where I'd go with that. All vasoconstrictors are biphasic drugs. So first they constrict and then they dilate.
Yeah.
All local anesthetics are vasodilators. And so that's why we put vasoconstrictors in them. It's not just about continued duration. So if in the way they broke down that drug, it got to that biphasic, it actually does dilate. So the lidocaine causes dilation, and the epinephrine also, after the endpoint of its biotransformation, causes vasodilation. And it's kind of the same theory of the person who has the wisdom teeth out, and maybe about 6 hours later, they're home and they call and go, oh my gosh, I'm bleeding. But by the time they finish the phone call, they aren't bleeding anymore. I have this, I suspect it could be, that kind of a phenomena going on.
Yeah.
And we're really close. If you're doing infiltrations, there's a lot of intermixing of all of those nerve fibers.
No, that makes sense. Okay, we got a couple more that are similar. So this one has to do with third trimester in pregnancy. It might have to do with weight, maybe, because they're asking about the maximum dose of local anesthesia that you can administer to an alveolar nerve block.
So there's like 3 questions in one there. So number one, if you're asking me about an IA nerve block, I'm going to say generally you can do that in one full cartridge. And I'm also going to say that I do that with articaine 1 to 200,000 for everybody. And I'm particularly comfortable doing that for a pregnant person because of the half-life of articaine. So for one cartridge, I have a 15-minute half-life instead of a nearly 2-hour half-life like with lidocaine. I'm able to use that small, quantity of vasoconstrictor, and that's different than 3.2 milligrams per pound for that patient. So any patient, I'm going to go 3.2 milligrams times your weight for the max. Okay. My difference is for an IA, I feel confident I can achieve that in one cartridge. And again, at the quicker, more rapid half-life, I feel very comfortable about that. And Malamed has written some great articles really looking at all of those features about drugs and really talking about the choice during pregnancy and lactation, really looking at the biotransformation, and it's being very quick.
That's a great resource. Thank you. And let's see, I had a patient test positive for cocaine on a drug test 2 days after dental treatment. He's blaming the use of topical anesthetic. Could this have caused a positive result?
Read the middle part. He was claiming
he's blaming that it was our topical anesthetic. That is as to why he's
drug test.
Yeah, for cocaine.
This comes back to half-life. So if you look at the half-life for that drug and show how quickly it can exit the body, that's the math that you would do. And they're not exactly the same categories, although everything started, with cocaine, but this is a half-life thing, is how rapidly would it break down and be biotransferred. And if he had enough in his system to test positive of a test, I'd be shocked that after that many days, they could still have maintained enough drug from the very minuscule amount you would have used. So I would, really take it back to the math and look at that half-life and the unlikelihood of it lingering in that quantity that long.
Great. Thank you.
Just an observation.
Yes, exactly. And then what are the indications for a true maxillary block?
The folks that I know that use them routinely are generally like dentists, anesthesiologists that are really getting complex cases. For you folks doing implants, if you were doing, a large unit, several units, what am I trying to say? Hemimaxilla or something. Then it could be one injection, and then you're going to get everything. You're not going back and doing anything extra.
Yeah, so a lot of like implants.
You might do some infiltrations for hemostasis at your particular surgical sites, but with people who are very comfortable and have developed a lot of expertise with these, they use them because it's one injection. they'll often give, 2 cartridges, maybe one from the palatal and one from the, the buccal side. But again, it's one for everything. It's like your IA, if you give it high enough. So it's the maxillary equivalent of a Gaugates.
Yeah, perfect. Okay, and last thing, can you please share your QR code for the anesthesia for adults and children, please?
I can.
Thank you. I'll let everyone get there.
And like I say, that one just came out in August.
Perfect.
And so getting things shifted.
Thank you very much.
You're welcome.
This has been a total pleasure. I really appreciate you bringing up the information about the GP too, because I think it's missed a lot, and I think you nailed it. The discomfort's really on us, and so it's getting comfortable and being able to practice that and give that profound anesthesia. So thank you so much, Kathy. Be sure to join us next week when we will have, as always, our business advisory panel, and our guest speaker will be Dr. Steve Carstensen, and his topic will be the importance of nasal breathing. So let's meet back here next week, same time. See you guys later. Thank you so much.